Welcome to the Peds Hub Pod, an educational podcast created by paediatric trainees in the Southwest, featuring reviews of journal articles and interviews with authors and specialists. Please note, these are our own opinions and do not substitute professional medical advice. Thanks for listening. Hello and welcome to the Peds Hub Pod. My name is Felicity Cooksey and I'm a paediatric trainee in the Southern Deanery. Today we're going to be talking about nutritional blindness. I'm very pleased to welcome Dr Denize Atan. Denize currently is an associate professor and an honorary consultant in neuro-ophthalmology at the Bristol Eye Hospital. She is also co-president of the UK Eye Genetics Group. Denize co-authored a paper in Archives Disease in Childhood titled Nutritional Blindness for Avoidant-restrictive Food Intake Disorder, Recommendations for the Early Diagnosis and Multidisciplinary Management of Children at Risk from Restrictive Eating. As usual, I'll put a link to the article in the show notes. Thank you for joining me.
Thank you very much for the invitation.
Could you tell us a little bit more about yourself?
Yes, so I'm a consultant ophthalmologist at the Bristol Eye Hospital and my specialty interest is neuro-ophthalmology. Essentially that means diseases of the nervous system that can affect vision or eyes. My research also deals with conditions that can affect vision or brain development, and that includes genetics and also environmental factors that can affect eyes and vision.
That's interesting. And how did you get involved in research to begin with?
Well, at the time that I was training in ophthalmology, a lot of major advances were happening in genetic research. So, for example, the Human Genome Project had just been published. There was work on the HapMap project. There were major step advances in DNA sequencing. And so it seemed to be an interesting time to do genetic research into eye diseases, and my PhD was focused on research into a condition called uveitis.
And how did this review come about?
This review came about through my clinical practice. We unfortunately had a number of cases presenting to us at the Bristol Eye Hospital or to colleagues at associated hospitals of children who'd lost their vision from restrictive eating. And we realised that awareness about the importance of nutrition to vision was really low among clinicians, and many clinicians weren't even asking about diet or nutrition in patients coming into hospital, and so the diagnosis was being missed. And so the idea of the article was really to raise awareness about the importance of nutrition to vision and try to come up with some guidelines and recommendations that could help others who might encounter these patients.
I don't know if it's just because of more awareness, but I've noticed in the last couple of years I've cared for children with serious complications from nutritional deficiencies, so with profound anemias, presenting with cardiac failures. We had one child with a vitamin C deficiency who originally thought had a malignancy. So it can be really difficult sometimes.
Absolutely. I think as doctors as well, we're trained to look for pathologies, because we know that food is widely available, it's not restricted like it is in other countries due to limited availability. You just have to go to the supermarket and see that there's lots of food available, but for whatever reason, certain children just don't eat that variety of food that's really important to their health.
And in the article, you're focusing on children and young people with ARFID, avoidant-restrictive food intake disorder. For those who aren't familiar with the condition, what is ARFID?
So ARFID is an eating disorder, but unlike anorexia or bulimia, these children are not concerned about their body weight at all. They're limiting their food intake because of other reasons. This may be something to do with the sensory features of the food, the texture, the smell, the colour, the whole environment around eating a meal.
It's highly prevalent but not limited to those who have autism spectrum condition. What do the NICE guidelines on ASD in those under the age of 19 years say about nutrition?
Prior to 2021, the guidelines did not mention feeding or restrictive eating behaviours or nutrition at all. But around that time there were two very well publicised cases of children who lost their vision from restrictive eating. The family of one of the children lobbied NICE very, very strongly to try and change the guidelines, to highlight the issue of restrictive eating and to try and include blood tests as a screening for nutritional deficiencies in children with autism spectrum disorders. And as a result of this lobbying, NICE then did an expert review of their guidelines. They looked at the evidence for restrictive eating among children with autism and decided that they would add additional wording to advise clinicians to look for nutritional problems, to ask about restrictive eating behaviours and to investigate as necessary.
And I was interested to see the data that you presented from a systematic review, which showed broadly there were two groups of avoidant eating patterns. Can you tell us more about these and how that can relate to changes in eyesight?
So yes, there was a systematic review looking at children with autism spectrum disorders who developed ARFID and complications of ARFID. And there were two groups of children. One group developed vitamin C deficiency and scurvy. The other group developed vitamin A and B deficiencies and lost their vision. And they looked at the type of foods that these children were eating. Both groups had very limited diets, restricted to less than 10 foods. But the group that developed scurvy or vitamin C deficiency tended to be drinking milk-based foods, a sort of chocolate milk type thing, but no fruit or vegetables, and so they weren't getting the vitamin C. The other group tended to be eating potato-based products, so things like crisps and chips. So they weren't getting the dairy, but they were getting some vitamin C from the potatoes, and as a result they were deficient in the vitamins and minerals that are important to vision. What that means is that the complications you develop from ARFID depends on what you're not eating. It's not that there's a particular food that's bad for your eyes, it's more the fact that you're not eating the foods that are good for your eye.
Quote from the paper which really struck me was that when you say that for a 7-year-old child to meet their vitamin A recommended daily intake, they would need to eat 10 kilograms of crisps, which really highlights the issue of how children can struggle to meet their micronutrient requirements when limited to a bland diet. And it makes sense that whilst height and weight measurements are important to growth, it can lead to false reassurance. And I think we see that with children who are drinking excessive cow's milk as well. They can have a completely normal weight, or if anything, be on the higher end, but actually still have a nutritional deficiency.
Absolutely, and I think there's a little bit of confusion amongst clinicians as well as parents about the difference between calories and nutrients. You sort of think you need food for energy, and yes you do need energy, and that's where the calories come in, but you also need these vitamins and minerals for health, and they aren't the same. So it's perfectly possible to eat a very high calorie diet that's very low in nutrients.
And how are you finding that these young people are presenting in terms of how's the diet impacting their vision? What kind of symptoms are they presenting to you with?
Well, in those who can communicate, they might say that they can't see. The problem with children with autism is that they can't necessarily verbalise that they can't see. So particularly non-verbal autistic children will not be able to say, you know, I can't see this, or that it's blurry, and it will be difficult for the parents also to realise that there's an issue with the vision. The child isn't verbalising that. So you have to look at the behaviours. So they may become more reluctant to go outside. They may be more dependent on their parents wanting to hold hands and feel unsafe. So they might feel that they have to be in a wheelchair or the pushchair more often than they would be otherwise. There may be other behavioural signs that happen with changes in lighting. So if a child goes into a dark room and they are unable to see, they may suddenly become very quiet because they can't see. So it's those little changes in their normal behaviour that can give you clues.
And if children have visual loss secondary to nutritional deficiencies, how do they tend to respond to treatments?
That really depends on how quickly it's picked up. The problem with children with ARFID is that generally the restrictive eating patterns have gone on for several months to years. So vitamin A, for example, is a fat-soluble vitamin. It's stored in the body, so it can take quite a long time to actually become deficient, even though you have that restricted diet for a long time. But if you pick it up quickly, the vision can return with treatment very quickly. If you don't pick it up quickly, then there'll be cumulative damage that's occurred that can't be reversed, and so the degree of recovery, even with treatment, will be more limited.
And can you tell us more about your proposed algorithm for the multidisciplinary management of young people with ARFID, which is in this review?
So we decided on a type of traffic light system, red, amber and green. So green would be a child who has restrictive eating behaviour, but they're still getting enough of a variety of food, enough micronutrients and calories to sustain their health. So there you want to address the eating behaviour so that it doesn't become entrenched, doesn't lead to further problems down the line. And so you would still want to refer those children for nutritional advice, dietary advice, and maybe some behavioural strategies to try and increase their food repertoire. So there the idea is about prevention rather than cure. Then there's the amber group, where the child has restrictive eating. They haven't yet developed complications from their restrictive eating, but they're at very high risk of developing those complications. Again, there you want to prevent the complications by addressing the behaviour, maybe supplementing the diet, and even screening for possible complications, checking the vision, examining them neurologically, checking height, weight, and general health. And there's the red group. These are children who have restrictive eating again, but now have developed complications such as vision loss. Here, you really want to treat them urgently. You can't wait for behavioural change. And there are various strategies that you can implement to try and improve nutrition straight away. So one might be parenteral nutritional supplements such as Papronet or intramuscular vitamin A and B12. But you don't want to wait essentially until you get the results of blood tests and investigations. You want to treat as quickly as possible because, as I said earlier, the degree of recovery is much less the longer you delay. You still want to address the behaviour, you still want to look at the diet in the longer term. You can't continue to manage patients with parenteral nutrition, but you have to adjust your management according to the urgency of the situation.
And which specialist members of the MDT do you think would need to be involved with these young people?
Need to be tailored to the individual child depending on which complications they present with. So if they have vision loss, then clearly an ophthalmologist. You may want to have a paediatric neurologist involved because vision and eyes are actually part of the central nervous system, so they may well have other associated neurological problems. If you have a child who has scurvy as a result of vitamin C deficiency, then they may well have hematological complications, skin, gum complications, and in that scenario you would want to involve hematology, might want to involve max fax dentists, dermatology, as well as speech and language therapy, occupational therapy, psychology, dietitians to address the behaviours and the nutrition.
When talking to young people and families about vision, do you have any top tips for history taking?
Well, in very young children, I always rely on the parents' account of their child's behaviour, how their behaviour may have changed or deviated from their normal pattern, how their behaviour is affected by changes in lighting, as we've mentioned, how they navigate the room, whether they're tripping over things, whether they're becoming more reliant, they want to hold hands or go in the pushchair. Those little behavioural clues in the history.
And in the review you also talk about, in terms of how ARFID can be managed, the behavioural strategies employed by SALT to widen food preferences, fortified foods, and also over-the-counter supplements. And an interesting point your review highlights is that caregivers should avoid hiding supplements. Could you tell us more about that and why we should be avoiding advising parents to hide supplements?
Because we know that children with restrictive eating behaviour appear to have very heightened sensitivity to food. So they're going to pick up if you are adding something that shouldn't be there. So a good example of one of the patients that presented to us was a child who really liked Monster Munch, and their mother decided to try and add supplements to the Monster Munch. But as he got older, he realised that she was always giving him packets of Monster Munch that had already been opened. And he cottoned on to the fact that there was something not quite right. And then he stopped eating the Monster Munch. So what that means is that the foods that they were already eating and accepting, they stopped eating.
Yeah.
So as a result, their diet becomes more limited.
It's a very good point. Practically, for yourselves, when you're doing a visual assessment, how does someone having social communication differences affect your assessment? How do you adapt your assessments?
So in very young children who are non-verbal and also children who have social and communication issues, you clearly cannot ask them what's wrong with their vision or what's different about their vision. And what you also realise is that many of our tests rely on them responding to us verbally. So if you think about going to the optician and having your vision checked on a Snellen chart, a letter chart, you are verbalising what those letters are. So you can't do that in children who are non-verbal. You have to look at their behaviour. And there are ways of doing that in very young children that involve preferential looking. If the child doesn't quite understand what you're expecting of them, again, they're not going to be able to do the test. It's the same for tests of peripheral vision. So if you want a child to look at a central target and you're bringing in toys or objects from their periphery and wanting them to respond to that, if they don't necessarily understand what you are expecting or how you expect them to respond in the test, then they can't do it. So that makes the assessment of vision much more challenging. It can also be very challenging to examine the back of the eye in somebody that doesn't allow you to look at the back of the eye, because it's difficult if you've got a moving target. So this is why often with very young children and those with severe autism, you might have to rely on an examination under anaesthetic.
Yeah. And if you had to give those in training one piece of advice, what would it be?
So I would say follow your passion. Choose jobs, choose a specialty that you love and enjoy. And don't worry if you don't know initially what that might be. Try out a few different things and don't have an idea, immediately about what exactly you want to do for the rest of your life, because that's a massive decision. And actually it's absolutely fine to take an indirect course. And what you may find if you ask people is many of them have also taken a very indirect course. They just don't tell you those bits where they've gone off track a little bit. So don't worry too much. You'll find it eventually, as long as you follow your heart and what you're genuinely interested in.
That's a very good piece of advice, thank you. Now, I'm interested in getting involved in research, but I'm not an academic trainee and I've very limited previous research experience. Do you have any top tips for people like myself who are interested in getting involved in research about how to start?
Well, again, I'd say follow your passion. So think about which areas of your specialty or medicine that you're genuinely interested in, and then you'll find that there are lots of unanswered questions within that specialty. The other thing I find that many trainees think about research is that it's limited to wet lab research. Like you have to be in a lab with test tubes and pipettes and things, otherwise it's not research. And that's not true at all. There's actually a very broad range of different types of research that are all equally valid and genuinely important. That could be clinical research, health delivery research, education research. There's all sorts of different types of research that you can get involved with, and some you can combine very nicely with your clinical practice. So don't worry if you have absolutely no motivation to do any wet lab research at all, you can do other types of research.
And overall, what's your take-home message today?
Ask about diet in the clinical history. So even if that's asking the child or their parents what they had to eat on that day or the previous day or the last week, but that gives you a huge amount of information about the nutrition of that child. So if that child is only eating potatoes and crisps, they're very, very likely to be deficient in a whole gamut of vitamins and minerals. And you'll get much more information just asking that question than you will from doing a blood test.
That's a very good point. And finally, we ask all of our guests if you have a book recommendation.
So recently I read Lessons in Chemistry, which I really loved because it's about a woman who's a chemist, and it deals with issues of sexism and racism. But as well as that, it's about a love affair and the chemistry between two people. And the main character also goes on to present a cooking show.
Oh, right, okay.
And so it's about cooking as chemistry. And so it talks about chemistry on a number of different levels.
Yeah.
And so I really enjoyed that book.
Oh, I'll have to give it a read. Thank you very much. Thank you so much for joining me today.
Thank you.
And thanks everyone for listening.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the PEDS Hub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch. Thanks for listening.